Hey everybody, great episode today with Peter O'Sullivan from Curtin University in Perth and Body Logic in Perth. We talk about tons of great stuff, so make sure you listen up.
Yeah, so in this little conversation, we start off talking about COVID because we didn't know we were already live on Facebook. And then we go back and we talk about who Pete is and what we're going to cover. This is really a fabulous episode, especially if you're interested in pain and people's pain experiences, and whether you're a clinician or a health care practitioner or general public. It's just such an interesting conversation talking to Pete, talking about his evolution in physiotherapy and how his thought processes around pain and people's pain experiences have changed. And Anthony and I both love this episode and enjoy it. It'll be coming right after the usual intro. Welcome to the Women's Health Podcast. I'm Marika Hart from Herasphere.
And I'm Anthony Lowe, the Physio Detective. Together we interview leading authorities, answer questions, and share our thoughts to provide the general public with the best quality information we can find on all aspects of women's health. Please remember the materials and content on this podcast are intended as general information and for entertainment purposes only.
They are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now it's time to get cracking with the episode, so whether you're out walking your dog, driving the kids to school, or just sitting back enjoying a glass of wine, we hope you enjoy the show.
Face-to-face work, because we didn't know if we were carriers and we could be potentially putting people at risk, or we were doing everything we thought we could do to protect people, but then we thought, oh shit, maybe we're actually, the worst thing about this virus is you can be a carrier and be very healthy. And look, I think we've been lucky, particularly in WA, really lucky. So
just so you know, Pete, we're alive.
Yeah, that's cool. Yep.
We can continue.
We are lucky.
No, just that whole sense of I've got colleagues all around the world who I communicate with who are just having such a shocking time, and not just the fact that they've got no capacity to care for their patients, or that they're providing telehealth, but the funders aren't providing support for that. So patients are basically just left abandoned, really. So people who might be, on a, surgical wait list get put off the list, and they just get stuck in no man's land, where, the physios might be prepared to provide telehealth support, but the funders are not prepared to support it. So I think it differs in different parts of the world. So, it's tough. It's been a tough time. And as I said, the levels of distress that we've seen in the community, and particularly people who got health comorbidities, and we see a lot of those patients. So either the older age group or people with health comorbidities, and a lot of our people with chronic pain have that vulnerability. So they're a really vulnerable group. And we know there's so much, comorbid anxiety and depression with our clients as well, and the anxiety levels have been through the roof. It's kind of like mass anxiety, and the more you watch the news networks, the worse it is, basically. So it's like being piped into your room and through your airways 24/7, and because people are isolated, they're naturally gravitating towards news services, I think, and it just ramps everything up. So yeah, it's a real cocktail for human distress, and we know that's a cocktail for pain. So it's tough time, but it's a great
even all the conversations. Yeah,
I think it's a wonderful opportunity for us as professionals to care for our clients. So, and it's been lovely to see, a number of our team, really reaching out and supporting their clients in so many different ways, like providing, home-based exercise programs. I mean, I've been busy through the whole time, reaching out to people who are just having a real hard time, and I think just that human connection that we crave or we need as human beings has been kind of cut off, and it's we can partly connect with that through video, and that's great, but it's not quite the same. It's not quite the same as face-to-face. And so it's been a really interesting kind of time of reflection around what our core, what we really do offer people, and what is the basis of our care, I suppose. And a lot of it is fundamental stuff around communicating and empowering and supporting and facilitating and helping people. I think the great opportunity there has been helping people actually find solutions for themselves, which I imagine would be very hard for practices that are very dependent on passive forms of therapy. To create that switch immediately would be tough. I think we're lucky that, we tend to promote a much more of around an empowerment model of care. So that's a much easier thing to do via telehealth than it is probably for people who are very dependent on passive forms of therapy.
Yeah, it's a difficult evolution that people have had to jump into, just depending on the model, and quite often it's it's also the people who come to see us who that's where the struggle is, because the physio might be the healthcare provider might be able to do that, but quite often, I know I've had a lot of messages, I don't think online's going to work for me. I really want to come and see you. Tell me when you're open again.
Yeah, exactly.
So it's a lot of that systemic cultural expectation stuff.
Yeah,
I think
it is. And it comes down to, as you say, those expectations of the patient. And sometimes, we've had people who have been reluctant, and then we just talk to them and they've gone, well, look, I'll give it a go. And it's like, then they're like going, yeah, that was a lot better than I thought it would be. The other thing I think to be aware of is that if people are in their homes, not everyone wants to be seen in their own home. There's that kind of personal vulnerability that occurs when you kind of go into someone's home. And I've actually been working from work, so I'm not in my own home when I've been working, doing the video conferencing, because I wanted to create that sense of like I'm still in my workplace, working, but for the patients, they're in their home. And I've had video calls with all kinds of stuff's happening in that environment. It's not a controlled environment. So that, in a sense, is a sense of vulnerability. And not everyone's proud of where they live as well. So, there's a whole lot of issues that kind of emerge around when you're actually videoing someone in their own space. And not everyone's home safe as well. Not everyone's home is a supportive, nurturing environment. And so often they come to us to be in a safe place where home may not be safe for them. There's all kinds of issues that do rise up around this whole aspect of providing care for someone through a video link in their home. Let alone their confidence for older populations, the confidence of using IT. That's the other thing that we've seen. It's like, it's some people are just like, oh God, no, I can't do that. And it's a telephone call, but telephone calls much harder.
Yeah, you can't see anything, right? I want you to bend over. Yeah. Oh, I thought you wanted me to sit down. Like, it's,
So you still can do it. It's just not as good.
Yeah. With so with that.
Just, before Anthony, sorry, we're on a lag, aren't we? I just wanted to jump in very quickly because I know that people are on the Facebook group now, and I know that the physiotherapy world knows who Peter O'Sullivan is, like pretty much most of the people around the globe. But I just want to quickly introduce for those that don't know Pete. So we're a few minutes in, but he's a clinical researcher. He works at Curtin University. He's a specialist physiotherapy therapist at Bodylogic in Perth. He's written over 250 peer-reviewed articles. He works a lot in musculoskeletal pain and its management. And Peter and his team are really, really passionate about supporting people with pain get back to doing all the things that they love to do. And so your background really has been very much around pain. But one of the things Anthony and I really wanted to talk to you about, Pete, was your sort of evolution and your story in working with pain. Because I know, like you were one of my undergraduate lecturers back in the day, and I'm sure what you were teaching then has changed over time, and we've sort of seen this. And Anthony and I love that, because what we feel is that we're constantly learning, and things that we think we know, we're just having to chuck away and evolve and go, that was okay, that's what we knew then, but we've learned something new now. But we would love to just hear your story, because
Yeah, so it's interesting. I kind of reflect on this often because that is really a huge part of my journey. Is like I trained in New Zealand, and that was kind of eclectic in many ways, but it was fundamentally influenced by models like the McKenzie model. So there was a very strong pathoanatomical kind of bias towards my understanding of pain back then. And remember, this was like I remember. In fact, I went back to Dunedin last year for their 150th Otago 150th anniversary, and I brought back all these memories. I remember sitting in the library and pretty much the only journals that were available were the spine journals, and I would and the Australian Physiotherapy Journal, and I would sit and read all these journals because the textbooks just were trotting out stuff that I didn't believe. Right at the beginning, I had a brain that just didn't cope well with being given information and accepting it. So I think that prefaces who I am. Naturally, I just believe stuff. But in saying that, probably as a person, I was someone who, I grew up in a home where my mum had a lot of health issues, but never really manifested them. So she always got on with it. She always coped. She always, cared for others. She always, she never really demonstrated much illness behavior, I suppose. But there was a sense that she was someone who was a very strong coper with stuff. And so that influence, I was young to 6 kids, I used to climb trees, fall off bikes, broke arms, always went to school, never had a day off. I'd wake up sick and my mother would go, well, off you go. And I'd go, but I got a temperature. And so I think that whole sense of, I grew up in an environment where sickness wasn't something that made you stop, that didn't take time off school. I just didn't. And I've never really taken time off work apart from, major health events that have really forced me in hospital. So that's kind of probably the undercurrent of me. I'm naturally an optimist. I'm naturally someone who, if someone provides me a roadblock, I'll find a way around it. That's just my personality. And so I'm probably someone who's got high levels of self-efficacy around, you can't do this, well, I'll find another way to do it. That's who I am. And then take that personality and put it into an environment where you learn all this stuff around pain and do this, don't do that. These rules that I hate rules. So kind of those two things I think didn't sit easily for me in terms of who I am, what I naturally am like. And then growing up in a profession, in fact, I applied for medical school before I even graduated physio, because I was like, oh, what the hell am I doing here? This is not a science base. This doesn't even make sense, a lot of this stuff. And I was really lucky that I was asked I kind of deferred a year, and I had a year of working in the hospital system where I worked both in musculoskeletal and in neuro rehab. And I really loved the neuro rehab. That was like, empowering people to move and to gain function and to get their life back. That really ticked my box. But the hospital system seemed really constraining, and I had a chap who actually really mentored me. I think he saw someone who was kind of excited to learn, and he provided me some mentorship. And then I got into I was offered a job in a private clinic in Christchurch under a very experienced chap who I think I saw a glimmer of what my job could be. So, someone who was, very skilled manual therapist, but also very interested in rehabilitation and the likes. And then I went to Australia, where I kind of got, I was, again, really fortunate. I did every workshop known to man in New Zealand. I could manipulate any joint in the body, and it frustrated the hell out of me that I could do all these tricks. I could mobilize, I could manipulate, I could do all this stuff. And it just seemed like this Band-Aid I was putting on people, where people come back with the same pain again. It's like, crack their back, no worries, out they go. Oh, it feels better. They come back and I've got to do it again. It's like, well, I don't want to do a job where all I'm doing is creating a Band-Aid for people. That didn't feel good to me. And that kind of probably my natural instinct is I hate creating dependence for people. I hate depending on people myself, and so to do that for others just fundamentally felt very wrong for me. And so went to Australia and worked under Bob Elvey doing my postgrad program in Perth, and he was a super clever chap, and he was kind of he's a strong manual therapy background, but was really influenced by Max Sussman and others around integrating neuroscience into practice. And could see all these collisions occurring where these kind of old thinking around the biomechanics, structural models just didn't fit with common understanding or modern understanding in neuroscience. So you could start seeing these kind of conflicts around practice and knowledge start to emerge. And, back then, there was this kind of first shift, I think, away from everything was about the segment and, joint dysfunctions and joint mobility, which was kind of like this really big focus back then. And it probably reflects physio going into kind of like almost a chiropractic model or, very strong biomechanical model of, everything's about the joint and the joint mobility, to then going, hey, these joints are actually controlled by muscle. So I kind of got sucked into that whole paradigm around, looking at the muscles. And that was around the 90s, where this kind of the whole core stability thing, and I jumped into that space. And during my PhD, the data that I was collecting didn't fit with the model. So, we were seeing muscles like multifidus overactive and couldn't relax. And they're like, oh, shit, how does that fit with the model? And I think what it really highlighted is that we come to a lot of what we do with strong beliefs, but actually physio is a really young profession, and particularly in the area of pain, it's a very recent emergent area. And we've tried to retrofit our beliefs into that space rather than actually say, hey, we need to let knowledge update how we work, instead of trying to hold on to old beliefs and practices and try and fit them into that space. And I think that's what our professions really struggle with, is that kind of updating and rejuvenating and going, actually, what is going on with these people? And I can, in my early post, manual therapy years, worked in a pain clinic where you touch people and they flare up, versus people with aches and pains that come in, you crack their joints and they feel good. And I really realized at that point that my interest wasn't to work just with the worried well, it was to work with these people who are profoundly disabled by pain. And they're the people where manual therapy just isn't a fix. It's, in some cases it makes them worse. And so, yeah, really my career since then has been a painful but kind of wonderful process of updating and ditching belief systems and updating knowledge, and realizing that, I could have gone 2 ways. I really could have dropped out of clinical practice because I would have, part of me felt fraudulent with the way I was working. But actually hanging in there allowed me to kind of realize that actually we have so many tools in our toolkit if we change our toolkit or update our toolkit. And it takes a lot of confidence, I think, and probably that's where I'm fortunate. I'm playful, naturally playful, and I'm a rule breaker. So, I would, my patients have been my test cases, really. And they've been kind enough to allow me to explore with them in their journeys, I think, and kind enough to be honest to me, to tell me where I've screwed up, that where I'm not helping, where I've made them worse, and to allow us together to kind of explore those things and for me to learn from them. I think probably they've been my greatest teachers in many ways. And then as a researcher with the group of people, wonderful group of people I work with, we've been able to explore hypotheses of going, look, this is what we think is happening. And almost inevitably we're wrong. Almost inevitably we've learned something that we never thought was there in the data, and we've had to update that. But that's a really cool process of looking at your data and going, shit, that is not what we thought was going on. How does that then make us update our knowledge, and how does that change how I practice? So that's kind of like a constant journey for us. And that's kind of pulled us into working with psychologists, working with, biomechanics, working with pain scientists, to have a kind of much broader view of understanding pain, and that's sort of where we're at the moment.
Wow, what a journey, Pete. That's fantastic, and you know, I think of, because you know you published those papers pretty much as I graduated, and I discovered them a little bit later than when you know, your ones on the pars defects, the spondylolisthesis ones, and you know, so here you go, you've got this whole stabilization strategy thing from the mid-90s, and then you know, the classification system from the mid-noughties, and then now the CFT type thing, and it's almost like you can sit back and view that journey and see the evolution of your change. A lot of the questions that we have from people who help other people is, you know, you talked about your natural playfulness, your ability to break rules, your you know, the people who are seeing you, challenging you and telling you, hey, you know, what you're doing is not working. Is there an internal process, or what's one step that you would like everybody to do to continue to evolve? Like, I mean, you said evolve the toolkit, but to really move forward, whether it's reframing why we're working, why what we do helps, or to even just push the boundaries in our bubbles so that, you know, we can challenge the profession on a larger scale.
Yeah, I think one of the things that's interested me around you know, what's happening in the world at the moment is you realise that we all live in little echo chambers. That might be around politics, but it's certainly the case around professional practice as well. I think surrounding yourself with people who are really honest, who can who feel free to challenge you. We see leadership around the world where anyone who questions that leader gets slapped down, and I think that's happened a lot in our profession as well, where we've had, you know, kind of like top down, you know, this guruism, which has been incredibly unhelpful, that you follow a guru and the guru tells you what to do and you just blindly do it. I think surrounding yourself with questioning, open, honest people where you can, your dogmas question constantly, and that's around your professional community as well. I think, you know, creating a professional community where there is open, honest questioning, there's no fear of questioning. I think it's really important, and the research we're seeing at the moment that's emerging is that people who can flourish clinically in those clinical environments, that the clinical environment, it's like a little ecosystem. It's like you can't plant a beautiful plant in a bloody garden full of weeds and put, you know, poison on it. And a lot of our clinical communities, well, I should be careful with that. I think we've heard from some people that their clinical communities and do not foster that the clinical communities are focused on getting a patient back and the business side of things to survive. And that's going to become even more of an issue at the moment, I reckon, around the kind of pressure points. But, you know, that fundamental, you know, basic values around caring for people, like fundamentally, if that is your drive and that's your value, then find a community with you, share that with others. I think they're really basic things. Question everything. I think we have a real risk of remembering our successes and forgetting our failures. And the people who don't come back to us, we forget. And the people who come back to us, we reinforces that what we're doing is really good. But actually, if we could talk to the people who didn't come back to us, we would hear a different story of that as well. So chase up the people who drop off your list and find out what's going on with them. Find out why. And no doubt you'll find there's social factors, there might be belief barriers, there might be that what you did flared them up, or they were pissed off with the way you communicated with them. So there's kind of, I haven't really answered your question, but there's lots of things I think you can do as a professional, and read broadly. Follow people who aren't promoting themselves. Follow people who are genuinely interested in the question and driven by that. Because, you know, we know that our whole profession's flooded with workshops that are about tricks and, you know, short workshops that teach people techniques. I mean, that's just horrible. We know it's bloody hard to change physiotherapist behavior. It's like it is to change human behavior. So when we get stuck in a way of working, it's really hard to change that. So we need to create an environment to nurture and foster change and questioning and growth. That to me is the key thing. And I think that's one of the great things that the internet has done, is to create opportunities and forums like this to honestly question. And look, there's not a day in my week where I don't sit back and think of a patient. I'm just going, I don't know how to help this person. I need additional support. And this person's got so much stuff going on in their life that for me to make it, to facilitate change is just hard for them at the moment. So, we need honesty as well to say we aren't fixing pain. We're supporting people with pain. We don't have a cure. It's a bit like, managing the coronavirus. At the moment, there is no cure. You're going to manage people. Pain, we don't cure pain. Pain is part of life. It's part of our society. We can help mitigate the impact of pain. We can help dial down pain, but we can't cure it. And we need that honesty within ourselves. So we stop trying to fix people and try to support people to manage and care for themselves in their life. There's not a day in my life I don't have pain in my body, but I'm not sitting there thinking about it. It doesn't stop me from doing stuff. So that's kind of like a reframing as well. I don't know if that answers your question.
So much for your honesty, Peter, because I think, it was actually really helpful. And the key message I got out of that was surround yourself by people who will allow you to ask the questions, to be challenged, to challenge yourself.
And grow you.
Keep learning. And to be in a supportive environment.
Supportive, safe.
As you say, there are some places that are quite toxic, but I think it's actually really great also to hear that you have struggles with clients too, where you think, oh shit, I don't know what to do with this person, and I need to, and because we all have those days. And when you're a young up and coming physiotherapist, or we have a lot of fitness professionals in our audience as well, and sometimes you feel like you're out of your depth, or you think I should know this, I should be able to help this person, and you don't know what to do. And if you're in an environment where you can actually team up with other people, get a second opinion, get another set of eyes, that's such a big part of your learning process. Yeah, it is. And,
I reckon in physio, I know you're talking about a broader group, but I think we're often afraid to get a second opinion because we don't want to look stupid. Like, all of us have been there. I mean, shit, every day we have people who we struggle to help. Like, it's part of a collective responsibility to care for people rather than, you did a crappy job and you should have done this. There's too much of that kind of finger pointing that goes on. And actually, who's got all the answers anyway? No one's got all the bloody answers. So we're all just on a journey. And when I'm done, the answers won't all be there. The model that we're kind of working with, it's an evolving model. It's not the answer. It's just a way that we've developed to try and help make sense of working with people with pain. It's not a fix.
Yeah. Absolutely. And totally confirming my biases, Pete. I don't expect you to listen to any or read anything that I write, but so much of what you say just rings true, and what Marika and I and so many who listen to this podcast believe. So it's really refreshing to, as a little minnow, just to say, okay, look, Peter O'Sullivan does this too. That's really cool. And I know that you don't think of yourself that way.
Just on that, I do not see myself like that at all.
I know. I am
just a
but we see you like that.
Like all of us. Well, that's a mistake, I reckon.
But we see you like that because we really respect you. My dog
sees me like that.
Fair enough. But on that, one of the things that I've really appreciated is your willingness to put like a patient demonstration up, and it really inspired me to go, you know what, I'm going to do the same thing too, because there is no perfect, right? And so I've filmed basically every patient demonstration that I've done on my courses. I think I've got like over 35 now. And I really appreciate that, but there's a bit of an argument about whether or not that should be a thing. Because, hey, maybe he only puts up the people that he helps, or do you know what I mean? Do you have, because lots of people think, lots of the participants tell me that they find it really helpful when they watch,
Yeah.
say, me or you. There's very few people that put like whole
Yeah.
consultations up. Um,
Yeah.
what do you think about that sort of thing?
Yeah. So I have really battled with that question a lot. And in fact, we've just, Raika Halopainen is a physio based in Finland, and she's done some research looking at a group of physios in Finland who've gone through a short training program that Stephen Linton, who's a pain psychologist, you might know of him, he developed the Orebro screening questionnaire. He's done heaps of research in the pain world. And myself, we ran this two short courses, and we brought a number of patients into that where we worked with them together. And this paper that's just come out, it kind of explored the ranges. So people didn't have a choice to come to this workshop. They were told to come. So they weren't electing to come because they went, oh, that'll be a cool workshop to go to. I know this person's work, so I'm going to agree with that. They were people who were told to come. And some of the people had a really hard time at that workshop. And some of them felt like the demos were fraudulent. So they felt like we'd set them up, that we'd set these patients up for success, that they didn't believe it, that it was grandstanding, it was guruism. And I sat back and thought, shit, if that's what people are thinking, that's really unhelpful. But on the other side of the pendulum, there were people who were saying that was the pivotal moment for them. They could see that they could see a pathway to change how they communicated and cared for people, and it was empowering. So I've kind of sat with that and gone, how do you set this up to say, look, if you do see a person in front of a group of people, there are absolute biases. There's, that's what it is. But I think the other side of that is in all of the clinical trials and any of the clinical data that's collected, not one of those patients have I treated. So I think, we're involved in lots of clinical studies. The outcome data from those studies are not in workshops. So the demonstration in a workshop is in itself got inherent limitations and biases because of what it is. And we have to acknowledge that straight up, obviously, and to say, look, these are the limitations and biases, and you don't get to see that person again and again. Although you might have seen the Fact and Fiction YouTube clip of people who I saw in a workshop who then were reviewed a year later, who talked to their journey of change. So that is kind of like that ability to follow people up, I think is really important. If you do see them in a workshop, I kind of feel like I have a duty of care to follow those people up and feed that journey back to the people who were on that workshop. That's something that we always try to do. So it's not just a one-off event, because one-off events you can stage to make them look like whatever. The other thing I think is a bit different in kind of the model of care is the model of care is not, I've seen this before where, a patient comes in and the super manual therapist does some tricks and the person goes, yeah, wow, that's amazing. Thank you very much. The model of care that we're interested in is to put the person in the center of their own care. So that is, they become the driver of their process of care. So that's a really different thing. So it's not like I'm the super, guru manual therapist and I did a cool technique that's freed this person from pain and hallelujah, they can walk. This is about a journey of saying, how can we help you unravel your story to make sense of it and give you tools to get back on track so that you can become in charge of your health. And I think that's fundamentally a different model that can be demonstrated in that way. And as long as we're acknowledging and aware of the limitations of any N of one, it is just a limitation of an N of one that we would never get published in a peer-reviewed journal, but it's just it gives you a point of reference as to what it might look like to communicate with someone who's frightened or distressed or angry or sad or frustrated or grieving or whatever. And psychologists have been doing this for a long time around that kind of peer review process of working with someone and someone kind of tracking that progress. And I think if we do it in that way, it's a much safer space. Again, long-winded.
That's a great question, and I think
replies.
I think from a personal perspective, I love watching. I love watching other people's sessions, and with both of you, actually, I've watched both of you record your client interactions, and I find it really, really helpful. And but I can see that argument too, that in a big workshop, you've got a client who wants to please you and doesn't want to say the wrong thing and wants to go, yes, there's all those things. And so I can see that the with the clinical trials, no one can say, well, that's the magic of Peter, he's really good with people, he's got this personality that clients really like. You've removed yourself from that process. Can we just take a little step towards the biopsychosocial model, which you've kind of obviously alluded to along the way, but we've talked a little bit about manual therapy, and perhaps it's not appropriate for those who have a more, long-standing chronic pain with lots of other factors that are driving this pain. We kind of wanted to, because at the moment there seems to be in these silos, it's like, manual therapy is evil and you should never ever do it. It's shit, and you do it, you're a crap therapist. And this idea that if you work in a biopsychosocial model, you just talk at people, or Anthony and I joke about the fact that some people almost consider pain science to be a verb. Like, I've pain scienced someone, like it's a verb. And I'd really love to hear your take on the fact that there is still a bio part of this biopsychosocial model. Look, I think totally. So biology is at the center of every person I see. It's I think of the people who I saw yesterday, where a number of them have underlying pathology, be it severe arthritis. I had a guy with he's got lower limb like bilateral knee and hip and ankle arthritis. He's been told he needs an arthrodesis of an ankle. So I've been working with him to just to build his confidence to move his ankle again. Now he's so much better with just building confidence. And I think what happens with these, I'm kind of circulating here, but what happens with these labels is there's all this other stuff attached. So, you got arthritis. People all of a sudden go, oh shit, I've got arthritis, I better not load that joint, it's going to wear it out, I better protect it. So it sets up all these secondary behavior responses, which is the worst thing you can have with someone with arthritis, right? So not for a moment would I say he's got no pathology. We work with pathology all the time. We work with people who might have, degenerate discs and with motor chains and inflammation around end plates, who have degenerative changes of, around the shoulder, knee, ankle, whatever. And that's part of what we deal with. So the bio is one piece of the jigsaw puzzle. It's not the puzzle. And unfortunately, when surgery is held up as a treatment, it's not the whole puzzle. So I'm dealing with a case at the moment. She's got, changes in her neck, and the surgeon wants to fuse 2 levels in her neck, but she's got all this other stuff happening in her life, which we know are predictors of poor outcome for surgery. So I'm trying to help support this lady to go, actually, let's work through this journey together to see whether we can get you to a better place. And look, at the end of the day, it's a really complex kind of scenario that we're dealing with around how we know the bio interplays. So we can have discussions around the role of your beliefs or your emotions or your lifestyle has on inflammatory cascades and levels of tissue sensitivity and the way you use your body and you guard it, for example. And we know that, there are a whole lot of factors that can wind the system up and leave a person disabled. So the levels of disability and pain intensity, we know, don't correlate that well with what you see in a scan. Other factors are in play. And so it's not to discount the bio, it's just to say it's not just about the bio, that the bio is influenced by your beliefs. The bio is influenced by your emotions. It's influenced by your behaviors, by how much sleep you get, by the food you eat, by your levels of adiposity, by your physical activity level. So that's the interplay. Now, so that's around the bio part. So bio is central to everything.
And the other parts is just, so I think it's more helpful to go thinking around a health model to go, okay, so how do we keep this person healthy, rather than a patho model, which is kind of myopic or tends to just focus on structure, to kind of think of the body as like, you know, I like the idea of an ecosystem. You know, how do you nurture the ecosystem? And that joint is part of your ecosystem, but so is your sleep and your mood and your relationships and your social environment. All those factors influence that ecosystem. In terms of touch, like I'm naturally someone who uses touch a lot. So, but I think this idea of, do we just talk to people? No, that's crap. Most of the power of what we see in the clinical learning is through behavioural experiments. That's the doing, not the talking. So I think number one, the talking is to kind of create a relationship, to understand the person's perceptions, their thoughts, the impact that pain's having on their life. The doing is the experimentation. So the behavioural experiments of like going back to explore the things that the person's frightened of or avoidant of, that's the doing stuff. And it looks like it's the doing stuff that has a profound impact. You can't do the doing stuff without the relationship and the trust. So the communication is embedded right through the journey. That's the talking. But remember that 70% of communication is nonverbal. So it's not just what you say, it's the way in which your expressions and body language and care for that person. That is all those signals we give people, which is not verbal. And often we go, oh, it's just what you say. Like education's just print. It's not. It's like we embed, the way we work with someone is about your care of the person. And that's way bigger than the words that you say. But touch is a powerful way in which you can create care as well. I think where I have, and as trained as a manual therapist, and I do use manual therapy, but I'm really careful how I use it, and I'm really careful the language that I use when I use it. And there are people who I elect not to use it on. But I will usually, apart from in this current environment, I will usually always touch them, touch to guide, touch to facilitate, touch to reassure, touch to care. So we know that touch is a very powerful means of communication. Why the hell wouldn't you use that? To me, that's how I would look at it. And there will be some circumstances where I wouldn't. I've had patients who come in where touch has been threatening and dangerous for them, and they've asked me not to touch them. And of course, I would respect that. There have been cases where they don't. I can think of a case where he was assaulted 30 years ago, and there was a strangling attempt, and his friend was killed. So it was a touch for him was highly threatening. He wouldn't let anyone touch his neck, but he will let me touch his neck now. So that's been a graduated process of letting me touch him, and touch for him was really important because the biggest threat was being touched. So where the biggest threat was being touched, to de-threaten him, touch was critical, but it wasn't touch as in, I'm going to mobilize your joint. It was, are you feeling safe for me to touch you now? Does that make sense? So I think how we see touch and how we see care for people is a much bigger thing. And if we see, our treatments are to mobilize joints, then we're dreaming, because we aren't. It's not what we're doing. It's kind of sits in a much bigger package. And part of that comes down to meeting the patient's needs and expectations, but not to fuel unhelpful beliefs and behaviors and dependency. And I think that's where I see manual therapy's got a real bad name, is where we see people who are frightened and disabled and dependent and have no way in which they can manage their own care. That's not good.
Yeah, it's wow. There's a lot there, Pete. Honestly, I wish we could spend tons more time on all of this stuff. So, so what I heard you say...
Well, there's always another opportunity.
Yes, we would love to take you up on that right away. I'm going to say yes, please. But the whole idea of integrating the whole thing, there is a place for everything. Maybe the reason why we're doing it, or being careful with how we do it, is more important than the what exactly. Sometimes you choose to do manual therapy and other times you don't. Like, even if I just quickly say something about what I do, with respect to the people who want manual therapy, I've got people who say, I've got the exercises and I'm doing them, and I've got the things that I can do to calm everything down myself. But I like it when you do this, and this is why I'm coming. Like, that to me is very different to, oh, I need you to put me back into alignment. You know what I mean?
Yeah.
Like,
and that's the messaging. Yeah, I totally agree with that.
Yeah. I just have a quick question. Cognitive functional therapy is something that you're developing, you and your team are developing. Are you able to, I've got 3 parts to this question. We're going to see if we can do it. Number 1, brief outline of what it is. Number 2, what do you think the minimum requirements for, because it's for physios at the moment, a physio to be able to effectively implement cognitive functional therapy and training around that. And the third one is, do you think fitness professionals could work using a modified model of CFT?
Yeah, okay. So that's sort of like another hour. It's like a whole story behind this. So when we started with this,
Jeez, Anthony.
and this, it's like, God, we just finished with 3 quick questions. So what is it? So when we started with this project, which was actually a trial that was done in Norway, there were a group of us who were laboured on what we would call this intervention. We're like, oh, what the hell do we call it? We can't just call it exercise and education, because it's not. It's different than that. It's grabbed elements of CBT, cognitive behavioural therapy, but it's not cognitive behavioural therapy. So we can't label it that. There's this really strong behavioural component to it, which is very functional. So it's not just lie down and do a bunch of exercises, which is kind of where I've evolved from. There's this whole functional behavioural component to this as well. And so when we wrote the paper in Physical Therapy a couple of years ago, we were trying to distill it down to what we thought were the 3 key elements of this approach. And it's prefaced on this framework of saying, hey, we know there are multiple factors that we know are linked to pain, and these are what the factors look like. And these factors are different for every person. So you need to screen for them. So at the very beginning, you need to do basic screening, and then you've got to explore these different factors with the individual. Based on the physical examination, a lot of physios have, historically being taught, to palpate joint mobility and all that kind of stuff. We don't do that because, 1, we're not reliable at doing it. 2, it doesn't really predict anything. So we're not into that, but we're interested in the behaviors. So, what is it? Some people come to us in pain, 1, because they're worried, 2, because they're distressed, and 3, because it restricts their ability to do stuff in life that they love. So we're interested in the things that people struggle to do. So it's very functional. So like, you can't sit, I'm interested in your sitting. You can't sleep, I can't roll over, I'm interested in how you roll. You can't walk, I want to know how you walk. You're frightened to bend, what are you doing when you bend? So part of that process is say, hey, is this pathology that's driving it? In which case we need to screen for it. So you've got to be able to have some basic skills in triage to identify a serious pathology or specific pathology that may be related to disorder, because it may not be okay for that person to just go about their job and get back to living because there are some underlying pathological process. So based on that kind of screening and the physical examination, which basically explores behaviour, and it looks at, the way in which people protect or avoid or guard the way they move, and it explores what happens when you take the handbrake off them and you disarm the system in a sense. And very often what you'll see is when you disarm the system, people actually have less pain and they can do things more easily. And so that you realise that in that context, the protective guarding is the body and the brain's way of kind of protecting something that's threatening. And for some people, that's real. It's like this, well, it's always real, but sometimes it's pathology driven, in which case trying to normalize the way they work will make them worse. In which case you don't push it. And in other cases, it's because they're frightened or they've got these really strong driven kind of protective behaviors that are probably influenced by all kinds of early life experiences and other stuff. So once you've gone through that process, the first question is this person, what are the factors that are going on for this person? And then the first thing we do is just kind of helping people make sense of their pain, which is why that's our first part. And it's not trotting out some prescribed pain, neuroscience description. Is to say, hey, based on your story, and I kind of see it like this: people come to you with a box full of jigsaw pieces, but they've lost the cover that shows the picture. All they've got is the pieces, and they come to us to say, I don't know what the picture looks like. I've lost the cover. And then you sit down with them and you go, hey, and they have might have a foggy idea of what it might look like, but they don't really know how to put the piece together. And we put the pieces down on the table and go, hey, do you reckon it looks like this? And they go, yeah, I think you're right. That makes sense to me. And often patients say, that makes sense, which is why we call it making sense. And it kind of fits with our understanding of illness perception, that making sense, people with pain are trying to make sense of it, and they make sense of it through the lens of their history, their experience, their social understanding, their beliefs, all these things. And so we try and help make sense of their pain through their own story, and that's why we put their story into their narrative. That makes sense. And then the second part is building confidence to engage with the stuff in life that gives them value. It's goal-orientated, functional rehabilitation, essentially. But a big emphasis on it is putting the person in control of that. So what we know about people in pain is they guard, they protect, they slow things up, they alter the way they move because they're trying to protect it. Those protective behaviors are usually not helpful if there's no underlying pathology driver, or even, you'll see that with, someone with an arthritic knee. Protecting the knee doesn't make them feel better, it makes them feel worse. So what we go about is to try and disarm the system, normalize the way the person works, and work in a graded process of building them back into function. The third part is addressing lifestyle factors. So getting people back into physical activity based on their preference, addressing things like their ability to, relax their body, discussing issues around healthy eating, managing things like sleep. Sleep is a really big deal for people in pain. So it's holistic. And I think the important thing here is it's an integrated model. It's not like it integrates care across a whole lot of different aspects to personalize the care for that person. So that's what the model in a nutshell looks like. How easy is it to train physios to do it? Well, we've got lots of projects at the moment running to see how easy it is and what the best kind of training is to help people go through that journey. And for some, that's why this paper that's just come out is really cool. For some, it's torture. For some, it's like, nah, not interested. And for others, it's a journey that's kind of opened up this whole new way of thinking and working. And that may be partly personality driven, that some of us just want to be told what to do. And this approach won't work well for people who want a recipe, because it is not a recipe. It's about person-centered care. It's about the person at the center of their care. It's about, meeting their goals, understanding their story, bringing it, that. So it does require a lot more brain work, but that makes it way more enjoyable, I think. So for some people, they can engage with this very easily. For others, it's an absolute tortuous process. And so to say how much time and training does it take, I think it would be a bit like saying to someone, how long does it take for someone to learn to juggle 5 balls? Now, for someone, it might take them 6 months and they still can't do it. Others might pick it up in a much shorter period of time. And that highlights that it's not just a training package that you deliver and people can do it. So what we've seen is that we talked about the watching, understanding the system, the watching, and then there's the doing. So we know it's like you got to understand it, you got to see it, and you got to do it. And the doing bit is the critical bit. And so that means, with one of the, all of the trials that we've run, apart from this one trial in Finland, which has been a really interesting study actually, because they were never had direct mentoring, is that I think it's really hard for people to adopt this model unless you've got someone who gives you direct point feedback. And that's certainly consistent with what we know in psychological research as well, behavior change research, is there's a level of mentoring that probably has to happen that occurs over time. There's one proviso on that. There's a group up in the UK who come to a number of workshops that I've run. So Chris Newton's is the kind of lead person on that. And he had then gone back to his workplace in the NHS and developed a group, and this is why these communities are really important, and has been working with this model of care over the period of 4 years, and has developed this kind of collaborative group that they've been working with. And I went to see them last year and spent a couple of days watching them working with patients, and they were awesome. And I had never given them direct mentoring. So what that tells me is that some people just get it and over time can develop the skills based on the resources that are out there to do it, where others, and I think generally, require more mentoring to do that. The third question is around the scope of practice. I think physiotherapy is, physiotherapists are quite well positioned. I've obviously got a bias, it's my background, to adopt this model of care. I think the elements of it, the kind of messaging behind it, it should be, like patient-centered care is the model of care that we should be delivering for anybody in a health environment. There are elements around CFT which are just about good care. And that should be something that we would see that could be adopted by people across any profession. And I kind of see it in terms of, at the very least, for people with pain, giving them sensible pain information, great messaging, being person-centered, helping them to achieve their goals and setting a pathway to do that. I think there are a lot of people who can deliver that model of care. There are others whose patients will really get stuck because their level of complexity is greater, and they may need someone with a high level of training and skill to do that. So I kind of see it as a step thing. So at a very broad level, we need to clean up our act across all our professions, that we're giving evidence-based information and evidence-based care. And that's something can be done, I think, at a very broad level. And then at a high level, we probably need people with high levels of skill to deal with really tough cases. And look, those tough cases probably need additional support with good GPs and psychologists. So we're kind of developing an integrated model of care at the moment, so that the psychologists and the physios and the GPs and the ex-phys can all be talking the same language, because that seems really important for people in pain as well. That was my rapid fire response.
How much time have you got, Pete, before you got to run?
Running out. That's why I stopped. Someone was trying to contact me.
Yeah,
I was thinking.
I know. We know you did say you've got just the hour and you've got to run because you've got patients. So we'll wrap it up, and we'll hopefully be able to get you back on again real soon, because I feel.
Yeah, no worries.
Yeah. Okay. Cool. Because Anthony and I did have so many questions, but it's so easy to talk to you for ages. So, just as a quick wrap up, obviously we've talked about Pete's journey within physiotherapy, how things have evolved over time. We've talked about what's happening in CFT and where that idea came from and how it sort of looks, and in a quick rapid fire way. What else have we talked about? We've talked about manual therapy. We've talked about some of the inherent things people might need to use things like CFT, and how for some people it comes quite naturally, and for others it's actually quite challenging, because you actually need to really, really think and delve into all these other factors. It's not a recipe. It's very much a process that you have to go through with your client, by the sounds of it. So developing that communication and that trust, doing all those behavioural experiments, So it sounds like it's a relatively, for some people it'll be quite a complex thing to learn. So you talked a little bit about the training side of things at the end there. So we've obviously smashed through a lot in a short space of time. Do you have any closing messages that you would like our community? So our community, we have general population, we have a lot of fitness professionals who listen, and obviously physiotherapists as well. Is there any closing things you'd like to say to the people out there? Look,
I think fundamentally, if I kind of explore in my own mind what drives me to do what I do, it comes back to those basic things we talked about. It's like, caring for our community is like bottom line. Can we reduce the suffering that pain has in our in our community? And that's a collective goal, and no one has the truth in this space. And I think, whatever models get put up will get criticized and critiqued, and that's great because it helps us to move forward. So I think, some people probably misinterpret our work as going, you're trying to create your own thing. We don't have a business. We're not selling anything. This is just putting something up, say, hey, look, this is an approach that is informed by evidence and practice, and it looks like it may be helpful, but look, when I'm done and dusted, something else will move on. and I think that's the journey. The journey is the key. And there are lots of ways to get to an end point. I think fundamentally, keeping the person at the center of that journey. It's not my agenda. It's about the person's agenda that we have to keep at the center. And that keeps us grounded, I think. So that we don't, like our egos and our agendas don't take over the process. And I think probably that's the thing that we have to keep coming back and checking back on as researchers and as clinicians and as people. And that's probably a good lesson for life.
Yeah, no, that's fantastic, Pete. Really appreciated that. Although tons of confirmation bias for me, so we would love to.
Well, we're probably just a little ecosystem reinforcing each other, right?
Yeah, well, I'm happy to do the questioning, to be honest. But really enjoyed that episode.
Really, what might be good is I'm just thinking if we do a future one, maybe your questioner, maybe your followers have got some tough questions that they would want to pose, because there's nothing like a tough question.
Amen. And totally happy to do that. Yeah. So if you're watching this or if you're listening, please post your questions in the various places where this podcast is being. We will collate them. We'll send them through to Pete. We would love to have you back on as many times as you want to come on, because we love sharing really good stuff, and we love your stuff. We, both, like you're in Perth, so Marika gets the benefit of being like physically near you. That's why I have this picture, just to show people where Perth is from me. But every time that I've interacted with you,
we're lucky to have her over here as well, by the way.
Oh, she's fantastic. I do call her the wiser one. But every time I've interacted with you, you've been brilliant, and love your passion for the profession, love your passion for people and the message of person-centered care. And we'll put all the ways that people can find out about your stuff in the show notes. Sure. We want to let you go, get onto your meeting. Really appreciate your time. And we'll chat soon.
Okay, good one. Lovely to talk to you both. See ya.
Thanks. See you later.
Bye.
Bye.
Thanks, Pete.
Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.